Good evening, everybody. Thank you for coming. My name is Dave Ressler, and I am the CEO, the administrator at Aspen Valley Hospital. And I'm not surprised to see so many people from the community here tonight. This truly is a community that cares about such an important topic as our opioid crisis. At Aspen Valley Hospital, I'm very proud of the work that we are doing in partnership with Pickens County Public Health, and it is together, along with our community, that we bring to you this forum tonight. I'm also very happy to say that we're privileged as a community tonight to have a very special guest. We're very honored to have Dr. Jerome Adams, who is our U.S. Surgeon General, who is able to come and share a few thoughts with us tonight. Dr. Adams is the 20th Surgeon General of the United States. He is also a board-certified anesthesiologist, and he served as the Indiana State Health Commissioner from 2014 to 2017. I think it's also very notable that he is still practicing anesthesiology. He is still doing the work, and he is still involved in our medical profession. Dr. Adams has a bachelor's degree from the University of Maryland, a master's degree in public health from the University of California at Berkeley, and his medical degree is from Indiana University School of Medicine. When Dr. Adams was the health commissioner in Indiana, he presided over Indiana's effort to deal with the state's unprecedented HIV outbreak by dealing with the causes of needles being shared among people who inject drugs. As a matter of fact, it was unprecedented nationally. And working together with the CDC, with state and local health officials and community leaders, he brought the widest range of resources, policies, and care available to stem the epidemic affecting that community. Dr. Adams' motto is, as the Surgeon General, is better health through better partnerships. He is committed to maintaining strong relationships with the public health community and forging new partnerships with non-traditional providers. He oversees the operations of the U.S. Public Health Service Commissioned Corps with approximately 6,700 uniformed health officers who serve to promote, protect, and advance the health and safety of our nation. Please join me in welcoming Dr. Adams.
Well, good afternoon, everyone. Is it afternoon, evening? Good evening, everyone. Thank you so much for the opportunity to be a part of your community forum and to address you for a bit. I'm only going to give brief remarks, but I'm going to go off script already, unfortunately, for you all. But one thing that wasn't in my bio is that I'm a dad. I have a 13-year-old son, a 12-year-old son, and an 8-year-old daughter. And unfortunately, when you look at the statistics, life expectancy in the U.S. has gone down for the second year in a row. And that's the first time this has happened in over 50 years. Put another way, I represent the first generation of parents in the last half a century that as of right now can't look their kids in the eye and say, "You're going to outlive me." That's not a legacy I want to leave for them. And we just had a quick meeting earlier. I got to meet the Kramers, and they were telling me about their son Dan. Their son Dan, who is struggling with substance use disorder, who will persevere. I'm confident of it. I'm going to pray for them. I told them I would pray for them. But, you know, we don't want anyone's kids to be in that situation. We don't want any parent to have to deal with what the Kramers are going through when we know we could have prevented it. And that's why it's so important that each and every one of you is here today. So important. There's 2.1 million people with opioid use disorder in this country right now. And it's whenever I come to talk to people, it's always, which statistic am I going to use? Is it that one? That one doesn't, resonate particularly with me. 2.1 million people, what does that mean? There's a person dying every 12 and a half minutes from an opioid overdose. That means if you all are here for an hour, there will be 5 people who've died across this country from an opioid overdose. There's a baby born with neonatal abstinence syndrome every 15 minutes in this country, 4 per hour. Opioid addiction is affecting every single community. And we know it's not as bad here in your county as it is in some places across the nation, but it's still a whole lot worse than we want it to be. There are still babies being born here with neonatal abstinence syndrome. I heard stories of several folks in your community who have died from overdoses recently. Still too high of a toll. And one of the things that we talked about earlier is that it's important for us to realize that the opioid epidemic is a problem, but it's not the problem. It's a symptom of a greater problem. It's a symptom of a lack of wellness in our communities. So many of today's problems, whether it's gun violence, whether it's suicide, whether it's opioid use disorder, whether it's cardiovascular disease, have shared risk factors. We know that trauma plays a role. We know that lack of social supports play a role. We know that hopelessness and despair play a role. And that's why we have to focus on upstream prevention. That's why I think the silver thread in the lining, in the dark lining that is the opioid epidemic, is the fact that it's given us the opportunity to bring folks together and to figure out how we can be better partners, to figure out how we can move upstream and solve not just the opioid epidemic, but the lack of wellness in our communities. And I talked about my kids, but this is personal for me in another way. My own brother right now is in state prison. His addiction and the lengths he went to support it are a key factor in his history of incarcerations. Prevention is critical. My brother's story is like so many others. He had unrecognized, untreated mental health issues, anxiety, depression, which he self-medicated with alcohol, with tobacco, with marijuana, got pills at a party. And I actually took my 2 boys, my 13 and 12-year-old boys, to visit him in prison. Number 1, because my brother needed to know that we still supported him. But number 2, because I wanted my own children to see the consequences of one bad choice at a party. And if you want to talk about something that's humbling, taking your 12 and 11-year-old kids who've grown up in a nice neighborhood, who you tried to do everything for, into a prison, having them have to get searched, having them have to go through the barbed wire, having them go through and hear the metal bars clang behind them as they go in to see their uncle. It's humbling, but the blessing is that my brother is still alive. And unfortunately, so many people in our communities aren't. As Surgeon General, I'm focused on the opioid epidemic, and we talked earlier with a smaller group. It can be overwhelming. It can be overwhelming because there's so many different parts to this. Is it the pharmaceutical companies? Is it the dentists? Is it the doctors? Is it the ERs? Is it the police? Is it our school systems that are failing us? But I'm focusing on 3 areas in particular, using my unique levers as a Surgeon General. I'm focused on putting naloxone in the hands of first responders and community members because I said a person is dying every 12.5 minutes of an opioid overdose. What I didn't tell you is that 77% are dying outside of a medical setting, 55% are dying at home. That means that over half of the people who are dying of an opioid overdose are dying on the other side of a bedroom wall, or just in the garage, or on the other side of a bathroom door. And I gotta tell you, I am just tired of going across the country and having to hear those terrible stories from parent after parent about finding their child dead in their home and knowing that we could have done something to save them. So that's why I put out the first Surgeon General's advisory in 13 years, helping raise awareness about naloxone, helping folks understand that anyone can get it via standing order. and helping folks understand that the only way we're going to dig out of this opioid epidemic is if we help everyone understand that they have a role to play, that they can be first responders. I'm working to prevent addiction before it starts. Again, everyone has a role. There's a killer in all of our medicine cabinets. I challenge every single one of you to go home tonight and go through your medicine cabinets. If you've got unused medications of any kind in there, get rid of them. Get rid of them. Most people in treatment, 2/3 of people in treatment, say they got started with a prescription opioid pill before the age of 25. 4 out of 5 heroin users got started with a prescription opioid pill. And here's the dirty little secret. It's usually actually not a pill that was prescribed to them. It was a pill that was prescribed to someone else. It was a pill that was prescribed to one of you all that you didn't use, that you left in the medicine cabinet, and then somebody got in there and took and diverted, sold, ended up at a party. It could have been the pill that got my brother hooked on opioids. We all have a role to play, and the way that we prevent addiction before it starts is by making sure we're turning off the spigot, that we're getting rid of unused opioids. So I'm trying to help patients understand the benefits of opioid alternatives, as well as how to safely dispose of and store their opioids when folks do use them. And then finally, I'm hoping to educate folks about the severity of the opioid epidemic. About half the public thinks the opioid epidemic is a problem. Less than half thinks it's a problem that rises to the level of an emergency. And even less than that think it's a problem in their particular communities. If you drive around Aspen right now, I'm sure you're running into folks who will say, yeah, we know there's an opioid epidemic. We know it's bad, but it's not in my community, not in my household, not in my neighborhood. We need to get over that because it's a problem everywhere. It's a problem everywhere, and we need folks to understand that. And we're working on a series of initiatives that will help folks understand the severity of the opioid epidemic and overcome stigma. If you go to crisisnextdoor.gov, you'll hear me share my story, you'll hear the president share his story, but most importantly, you'll hear folks who are in recovery, who are demonstrating that recovery is possible. Because there's bad statistics out there. I mean, I could hit you all night long with bad statistics, but at the end of the day, we want folks to know that recovery is possible if everyone plays a role. Whether we're looking to combat the opioid epidemic, improve our national health outcomes, improve our economic prosperity, or improve our national security, we all need partnerships, we all need collaboration, and you all are doing that here in your community. At the U.S. Surgeon General, standing before you right now, I'm an anesthesiologist, trained in acute and chronic pain management. I'm the Surgeon General of the United States. I was at the helm and dealt with the largest HIV outbreak related to injection drug use in the history of the U.S. But even I couldn't stop my own brother's addiction. If I can't do it alone, no one can do it alone. And that's why, again, I want to thank you all for being here. And I'm going to shut up now because I want you all to listen to the wonderful panel about what's going on in your communities. I do want you all, if you haven't seen naloxone, you see that this is the nasal version of naloxone. There's also an injectable version. Super easy, super easy. If someone is displaying signs of an overdose, they're blue, they're non-responsive, first thing you want to do is rouse or try to stimulate them. Try to wake them up because you want to make sure it's not just some college kid who did an all-nighter trying to study for an exam. But you want to rouse or stimulate them, and if they don't respond, then you want to call 911. Why is it important that you call 911 if you have naloxone? Well, with fentanyl and carfentanil out there, we know that naloxone may not fully revive them. It may buy you enough time for the ambulance to get there so that they don't die, but it may not fully revive them. Or it may wake them up temporarily, but not last as long as the fentanyl or carfentanil will. And if you don't call 911, then they could still die. And I said I was going to end, but one more thing I want to address that's critically important. There are a lot of folks out there who think we're enabling folks by giving them naloxone. Can't tell you how frustrated that makes me. What's the alternative? We're going to let them die? We're enabling recovery when we provide naloxone. I'm going to finish with a story because I like stories. I met a man named Jonathan young man named Jonathan when I was in Rhode Island. Jonathan's father died from an opioid overdose. Jonathan's brother died from an opioid overdose. Jonathan was misusing opioids. Remember when I told you unwellness in our communities? We've got to break that cycle. Jonathan overdosed himself. His roommate had naloxone. Jonathan's roommate was able to give him naloxone, and then he went to the emergency room. He was connected with a peer recovery support coach, someone who'd been there, someone who was able to reach him, who could say, I've been through what you've been through, got him into treatment, got him into recovery, and Jonathan is now a peer recovery support coach himself. Those are the stories that we need to help folks hear about, that we need to share. Recovery is possible, and that life that you save, that willingness to give someone naloxone, may be the key to creating the next Jonathan who's out there saving many other lives. That's how we dig ourselves out of this hole that we're in. That's how we overcome this opioid epidemic. That's how we start building well communities. So thank you again for the opportunity to be here, and I look forward to a robust conversation. I'm looking forward to the panel. It's an honor to serve as your United States Surgeon General, and know that I'm committed 100% to making sure we use this tragedy as an opportunity to help provide healing on a larger scale. Thank you.
Good evening. I'm Lori Malloy, the Chief Clinical Officer of Aspen Valley Hospital, and I'll be facilitating the conversation tonight on the opioid crisis. Where else but Aspen can you plan a community forum and just happen to have the Surgeon General of the United States ask if they can come be a part of that on the given evening? We are so fortunate in this community. So again, I want to thank you for coming and sharing your thoughts with us. I think it just served. Oh, we will. We will. The fact that the Surgeon General is here only highlights the fact of how important this conversation is to have as a community. So thank you all for coming. The format tonight is that we have two speakers, one that will talk about kind of the state, what's happening with the epidemic statewide, and then we'll have the local level perspective, followed by a panel discussion. When you came in, you were given cards. If you have questions, we'll hold the questions until we get to the panel discussion, and we will have some people that will come down the aisles and pick up any questions that you have, and hopefully we'll be able to address all of those this evening. So I'd like to introduce our first speaker tonight, Dr. Robert Valek, who's the director of the Colorado Consortium for Prescription Drug Abuse and Prevention. Rob is a Colorado native. He's a graduate of Colorado University and is a professor of pharmacy and family medicine. For the past 18 years, he has worked on this topic and is now doing so on behalf of Governor Hickenlooper to develop state-level responses and support local needs as well. So please join me in welcoming Dr. Robert Valek.
Thank you, Lori, and thanks everybody so much for the opportunity to come and speak with you this evening, and hopefully it's very difficult to follow the Surgeon General. Didn't expect that. I rarely get nervous speaking anymore. Now I'm totally nervous and shaking like I have to follow the Surgeon General of the United States. Okay, breathe, right. But my role basically is, as someone who cares about this a lot and has worked on this for my professional career, is to go around the state. And 5 years ago, the governor asked me, and it's one of those things when the governor asks you, you kind of say yes, you get voluntold to do something, and said, please, carry this message around the state, raise awareness, get people collaborating and talking, and try to do that. And so it's very gratifying to be able to come to all the different counties that I'm able to and try to share this important work. The objectives basically are to try to take things, the Surgeon General, you aren't going to get a better job setting the stage at a national level. I'm going to try to take it one level down to the state level And then the next speaker will talk about things at the local level to kind of drill down further to local level responses. And I'll try to set the context for you for what's going on in Colorado and how we're responding to this. So just diving right in. As the Surgeon General noted, over 63,000 people died from drug overdoses 2 years ago in the United States. That's 1 every 10 minutes, or in this case, 9 more during this session tonight. 2/3 of those involve prescription drugs, and most of those are the prescribed opioids. In Colorado, 2 years ago, there were 912 drug overdose deaths, of which 504 were opioid involved, which is the number we track at our state level. And that's anything that might be a prescribed drug, like a Vicodin or Norco, which is one opioid, or things like Percocet or OxyContin, all the prescribed ones, or heroin. And put those together, and we track that number to see where we are and how things are going. And that was 504 2 years ago. Last year's provisional data are not encouraging, but follow national trends. Basically, things are up about 5 to 8% across categories. Prescription drug overdose deaths of only the prescribed opioids are going up again. There were 329 2 years ago, or 3 years ago. 300 we thought were going down, and now we're back up to 357. So it was kind of a blip. People think, oh, they're going down. Unfortunately, most of these overdose death rates are rising for virtually all opioids. Same thing for heroin. It looks to be flattening, but I've already heard from some folks at the Colorado Department of Public Health and Environment that that number is likely to be greater than 228 when the final numbers are in. Fentanyl, people say, is maybe not here in Colorado. The coroners that will tell you there are MEs that are doing exams will tell you, yes, it is here in Colorado. And even from the counting that we do have, we had 74 fentanyl-related deaths last year in Colorado, and that number is growing very rapidly. So fentanyl is here. We talked to one of the MEs that I know is in Arapahoe County. She had 2 of those on the table last Friday when I'm driving to a different event, and said, you know, I can't really talk for my weekly update. I have 2 fentanyl overdoses that I have to get to before I can go home. So it's very much an issue here in Colorado already. And the problem, as the Surgeon General noted, really knows no bounds. You know, economic, social, ethnic, geographic. It really truly is an epidemic. And the CDC, another agency of the federal government, says this: we have to view this as one of the top 4 epidemics facing our country: cancer, obesity, heart disease, prescription drug overdose death. And we have to view it in that kind of conversation. No one would disagree that cancer is a big deal and we need to address it as a major killer, or any of the others. But we have to view this one this way. In Colorado, back in 2002, this is a map of opioid overdose deaths across the state. And in these middle county sort of shading that's about orange here, like Fremont, Tiller, and El Paso, is roughly the national average, the middle shading, for prescription drug overdose death, opioid overdoses. Anything lighter is below the national average. Anything darker is above the national average already, like Denver County and the San Luis Valley. Even in 2002, this was 3 times the national average in the San Luis Valley, so it's already an issue. I'll activate this map, and you can watch this rate go up. Darker is worse over the intervening dozen years, and it's not a pretty picture. Just to 2014, and I'm not smart enough to figure out how to get inside and add the new numbers and make the map work, but you can see that virtually all areas of the state have gone up. The San Luis Valley and the lower Arkansas Valley are 4.5 times the national average in opioid overdose death rates. Virtually every county in Colorado has gotten worse. People ask about Mineral County, and I joke because there's only 4 people in Mineral County. If one of them had an opioid overdose death, theirs would be the darkest red on the scale. It would be a 25% overdose death rate. So it's only a function of low population that it looks like there's not a problem in Mineral County. It's everywhere in Colorado and represents a 5-fold increase in a single cause of death in a 12-year span. Anybody in public health, anybody not in public health would understand that just doesn't happen in the United States. Nothing goes up 5-fold as a single cause of death in a dozen years. And the only thing that has caused decreasing lifespan that the Surgeon General mentioned is things like world wars, famine, plagues, those kinds of things in our history that cause decreases in lifespan. So it's really, really sobering. In fact, things like major public health concerns like motor vehicle traffic deaths have gone down over the years. Still, it's not perfectly safe to drive on the highway, but it's getting safer relatively as a cause of death over time. firearm-related deaths are flat over the last decade. And yes, we need fewer of them, but they're not growing, recent events notwithstanding, as a cause of death. What's growing is drug overdoses, to the point where it's eclipsing those other causes of death in the last 5 or 6 years, and that really gets our attention, obviously, as public health folks. And as I mentioned, it's really the prescribed opioids that are the big driver of these. Benzodiazepines are second, but the vast majority of those are on board at the same time, where someone overdoses with an opioid, a benzodiazepine, and alcohol in their system is the most common thing. So it's increasingly rare that people die of an overdose of one thing. It's ordinarily now we call them polydrug overdoses, 3 or 4 different substances on board at a time. But that's, as terrible as this is, it's only the tip of the iceberg. For each of those overdose deaths, there are 10 treatment admissions for abuse, 32 emergency department visits for things related to the abuse. So that's something like an overdose itself, an infection from a dirty needle, HIV infection, something that's directly related to the opioid abuse. 130 people who meet diagnostic criteria for substance use disorder. And most troubling of all to me is for every one of the overdose deaths that we see, when you survey people, for every one of those, 825 people will admit non-medically using an opioid in the last year. And it's a number we track called self-reported non-medical use. But really, it's this canary in the coal mine that people that the Surgeon General mentioned are using the leftovers, maybe taking someone else's or something of their own for a different purpose. For those 2 reasons, there's 825 times 550 in Colorado that admit it non-medically using. So tens of thousands, and across the country, tens of millions of people reporting that they non-medically use opioids. And that puts them at risk of moving up into dependence and having things that send them to the emergency room or into treatment, and unfortunately, oftentimes, overdosing and dying. So it's we're feeding this machine of people who are non-medically using opioids and wondering why the number keeps going up of overdose deaths, and we're not doing enough to stop it. So Dr. Adams was right. We have to shut off the spigot and do a better job of that. The cost of this, if you try to cost this out to the country, is tremendous. Different economic estimates, anything from 80 to 100 billion a year. The president's own economic advisors say this is a $500 billion a year problem, 504 billion a year. An independent institute that I happen to follow, Alterum, says it's in the last 15 years or so cost the country about $1 trillion, and in the next 5 years it's going to cost us another $500 billion. So no matter who you listen to, it's a very big number, affecting communities, affecting businesses, productivity, affecting families, the ability for people to care for loved ones, the costs of providing the care, the cost for criminal justice. All of the costs put together are astronomically large, and we have to get our arms around it. As the Surgeon General mentioned, we need to get people into treatment. One of the last major issues that we're facing is we just don't have capacity. If someone's experiencing an opioid use disorder or any substance use disorder, to easily and quickly get them into treatment. We have what's called a 90% treatment gap, meaning in this country, there's over 21.6 million people needing substance abuse treatment, but only about 1/10 of them get treatment in a given year. This would be like saying for 100 people being diagnosed with cancer, sorry, only 10 of you get to have chemo or radiation or surgery. The other 90, we don't know what to do with you. It would be completely unacceptable. We would march on Washington and no one would leave until we figured out how to deal with that if this were cancer. And that's how we have to view this, because this is a chronic, relapsing, remitting brain disease, is addiction. First use is a choice. Addiction is not. If it were, heroin addicts would just stop using, and it's impossible. So they must have treatment, and we must ramp up treatment capacity. In Colorado, this is another map from the Colorado Health Institute, who I give all the credit because I can't make the maps with the colors. Black and white slides, you can see mine. But the Colorado Health Institute tracked where there is access to evidence-based medication-assisted treatment, like methadone, buprenorphine, Vivitrol. And in counties that are dark red, there are 0 treatment facilities. So someone has no access whatsoever to FDA-approved MAT. In this county, it's better, but even in counties like Douglas or Pitkin or Fremont, I don't think anyone would tell you, we have got this figured out. Anyone who needs treatment can just walk in and get it. You know, it's like going to the emergency room. If you break your ankle, you know where to go, and Dr. Levin will fix you up. And you know where to go, right down the street to the hospital, to the emergency room. It's not that easy for treatment, and it certainly isn't. In most of Colorado, there is simply no access to it at all. So we need to work on that. So hopefully I've convinced you we have a problem. It doesn't take much, but these are kind of sobering statistics. You know, and how did we get in this mess? The Surgeon General laid out a lot of this, but basically we started laying on the opioids really thick about 25 years ago. And over a 15-year span, we increased this fourfold, the amount of opioids we give out per capita in the United States, to the point where in 2013 we peaked at 259 million opioid prescriptions going out at retail. It's enough for every American adult to have a bottle in their medicine cabinet every year. 2 bottles every household every year. Average number of tablets was 55. So 110 tablets. We're giving out 11 billion tablets a year. This is down now to 8 billion. I don't think it's low enough. The spigot is getting shut down, but we have to really crank down on the spigot a lot harder than we are because there's too much going out, too many leftovers, too many people still getting started on the problem. Why? A lot of things happened that the Surgeon General mentioned. We had increased recognition of pain, a very well-motivated thing when I was in school. We have to treat pain better. We need to recognize it better. I don't disagree with any of that. I do disagree with pain needs to always be treated with an opioid. This is the best thing we have. Not true. We have other medications like Tylenol and Advil that you may have heard of, like in your medicine cabinet, that are okay to leave in your medicine cabinet. You take those rotating every 4 hours and you get 55% pain reduction for musculoskeletal pain. Opioids will give you about a 30 to 33% reduction in musculoskeletal pain. And so I, as a pharmacist in 1987, said, I'm not afraid of opioids. I would just rather use the stuff that works better. So that's what's in my medicine cabinet. And I always tell people, ask a pharmacist what's in their medicine cabinet if you really want to know what to take, because they'll know what to avoid and what to take. And that's what I've got in my medicine cabinet, and you can get it for $4. We also know that there was a lot of increased attention to pain as what was called the 5th vital sign. So people really asking about pain, and it's, again, well-motivated. We want to treat people's pain. Drug company advertising and promotion. In case you didn't know, the United States pharmaceutical industry is extremely successful and very good at marketing. You see direct-to-consumer advertising on the TV virtually every day for every condition imaginable, even conditions that you may not even realize are conditions. So they'll create a drug and then create a market for the drug. Very good marketing from a business perspective doesn't necessarily mean medical need for everything that a pharmaceutical company is advertising. The drugs themselves are very powerful if not used properly, more so than people think. If it's in my medicine cabinet, it can't kill me. Absolutely not true. Docs aren't well trained in opioid pharmacology and addiction and treatment of addiction. Most docs will tell you this. Even docs that now practice addiction medicine say, oh, back in med school when I was originally in training, we didn't get anything in that. Got 1 hour on opioid pharmacology and go, start writing prescriptions. And nothing on addiction. I never know, I don't know what it looks like, I don't know how to treat it. That's for addiction doctors to do. But we don't have enough addiction doctors. So it's difficult. And then there's a strong black market for these products. Some people even will start on these and try to continue to obtain opioids, sell them on the street because of the street value, and then turn to heroin because it's a quarter the cost, and have a heroin addiction that they feed with selling prescribed opioids. This happened to a little old lady in northeast Colorado who was a patient of a friend of mine who's a practitioner that I asked, really, this person's getting 180 OxyContin every month for the last 3 years and you've never asked about it? Do a urine drug test just to see. And just tell her, this was a woman, tell her that I'm going to start drug testing all of my patients once a year just as best practice. And before he could even say the word urinalysis, she confessed and said, I've been selling it so I can make rent and all that. She wasn't using heroin or anything, but she was just getting the opioids to sell them on the street and pay for rent. So there's a strong black market for this that we need to be aware of too. So all of these things going together really are a tough thing to try to turn this ship around and come around and bring it to where we need it to be. So how does it most often start? We're not the biggest prescribing state in the country. We're ranking somewhere between 37 and 45 in terms of prescribing. Our doctors don't do a bad job at all And they respond faster than physicians in most states to changes in practice, that we need to do things better. A very progressive bunch of docs in this state. So we've never been the highest ranking state for prescribing. We are among the highest states in self-reported non-medical use of substances. 6% of people saying they misused an opioid in the last year, admitting to it. And people admitting to bad behavior, we know is always an underestimate, right? How many of you exceeded the speed limit coming over here to the event tonight? I did, because I had to get over here from me. But not every, I bet there's more than just me in here exceeded the speed limit. So I'll bet that 6% number is actually higher. And that's what's kind of scary to us. And if you ask people, as the Surgeon General said, 70% of people who start off and end up in a bad way started off with stuff, the leftovers in the medicine cabinet. 70%. That's the most common scenario, was like, his brother. Also significant is that 17% start with their own leftovers. So it's like, well, I had this leftover from a tooth extraction way back, and my back hurts, or I got a headache, or whatever, and I'm going to start using this opioid, even though it may not work for your headache. In fact, it won't work for your headache, your migraine. People do it all the time and then end up going down the wrong path. So that's 87% of this problem, is the leftovers. Also significant is doctors prescribing opioids after surgeries, whether they're major or minor surgeries, it doesn't matter. Minor surgeries up here, major surgeries down here, really doesn't end up mattering. For someone who wasn't on opioids before surgery, 1 year later, 6% of those people are still taking them after a minor or major surgery. And we know the post-surgical pain is real, but does not last a year for anything, unless there was a problem with the surgery or something didn't get corrected with the surgery. But as a matter of course, we should not have 6% of people still using them a year later. So there's a slice of this that doctors have to own. There's a slice that the pharmaceutical industry and pharmacists and patients have to own. And this just shows that everybody has a piece of this problem. The Surgeon General mentioned this, that most heroin people who are addicted to heroin will tell you, 65 to 80% of folks will tell you that's where they started. Prescribed opioids, leftovers. Nobody picks up a needle one day and injects heroin out of the blue, just for the heck of it. So what's going on to being done about this? The President's Commission at the federal level has said this is a public health emergency, and the President has declared it one. There's a lot of things being recommended for treatment expansion, more continuing education for doctors, more naloxone, better use of databases to check to see who might be doctor shopping or pharmacy shopping, and other kinds of things suggested at the federal level. The CDC, the Centers for Medicare and Medicaid Services as a payer, the FDA is involved, saying now there's a black box warning on all opioids. It's warning doctors, patients, and pharmacists that if you take these things and you take enough of them long enough, you will become addicted and you will die. It's right there in the black box on the label. So consider yourselves warned. The FDA can't do anything more other than just pull them all from the market. And they pulled one drug last year, Opana ER, called hydromorphone. They recommended it be pulled, and the manufacturer just quietly said, fine, we'll take it off the market, which never happens in a big market like the United States. A company just voluntarily withdrawing a drug. The DEA is doing what they can as well within their authority. In Colorado, we have a statewide plan to try to address this problem that the governor did strategic planning 6 years ago, and then asked me, would you go around the state and implement this strategic plan? I said, sure, so here I am, trying to do this in Pitkin County. We work in a variety of ways trying to educate the public, right here, where we are tonight, working on public awareness events with local communities to try to raise awareness. We also work with educating doctors, creating a safe disposal program, naloxone access, talking with law enforcement, how do we try to get a handle on this crossover epidemic into heroin, giving a voice for affected family members and friends to advocate for policies and programs at the state level, having treatment and recovery supports for people and creating new programs at the state level and arguing for federal and state monies to create better programming, and then again following with better data to see how are we doing and how big is this thing. So we have a lot going on at the state level to try to turn then and support local initiatives. The last thing I'll mention is that we have an interim study committee in our legislature, which is basically summer camp at the legislature. Some years it's for fracking, or 1 year it's for roads and prisons or whatever in infrastructure. Last year, and again this year, there's opioid summer camp for the legislators to say, hey, how are we going to address this? And the legislators spend 40 to 50 hours of meetings off session, hearing from experts, hearing from people around the state. What do we need? What does the problem look like in Pitkin County? What do we need that's going to help us? And then pass laws to help us do things and improve the state of affairs in Colorado. This past year, we passed 5 of 6 bills from this committee. Everything from more money for prevention and education, to limits on doctors so they can't prescribe as much on the first prescription that someone gets. Not if you've been on opioids for a long time, but the very first prescription, the doctor can no longer write more than a week's worth supply. So they can't give you 90 or 180 tablets on your first prescription. They give you a week's worth, and if you need more, you can get more, because we have found that 90% of people don't need more than a week. So why give everybody a month's supply and feed the leftover problem? So it really makes sense to limit that first prescription. Chronic pain's a different animal, but we think this is very important, and our legislature read the data, listened to the experts, passed this law with the blessing and support of our state medical society, who said we need this guardrail and we accept responsibility for our part of this. And that's unprecedented. If anybody knows, with working with medical societies at the state level, they never, ever, ever, ever ask for regulation. And they came to the table and said, we need something, we need a guardrail to help us enforce with our doctors. So this was a very successful effort with our task force working with the legislature, trying to do collaborative things. And we encourage people afterwards, if you want to get involved, to talk to me. Go to our consortium webpage, submit ideas, email me, and I will take your idea and walk it to Brittany Pedersen at the legislature and say that a citizen in Pitkin County said, we need this. And we will talk about it and we will try to deliver it. And that's our job. And the governor tasked me with it to go out and listen, share the message, but listen back from communities and bring this back to the State House so we can act on it. So I appreciate your time, and I'm really look forward to hearing more about the local initiatives. Thank you.
Thank you, Dr. Valek, for giving us such an excellent understanding of the breadth of this problem and the complexity of it at the state level. Our next speaker, Dr. Kimberly Levin, will give us a perspective on the problem in the community and what's happening. She's our Pitkin County medical officer for the last 4 years. She's also a practicing emergency physician at Aspen Valley Hospital and Valley View Hospital. She's a graduate of the University of North Carolina Medical School and the School of Public Health. She attended residency in emergency medicine at Stanford University, and she is board certified in emergency medicine. We are very fortunate to have someone leading our public health in this community with her level of energy and enthusiasm and her commitment to make a difference in the opioid crisis in our community. So please welcome Dr. Kimberly Levin.
Thank you, Lori, for the introduction. I want to thank Dr. Valek for coming up here and being accessible to us at the state level, and for all the information presenting the gravity of the situation, the magnitude of it at the national level and at the state level. I will be talking about it at the level of Pitkin County and locally in our backyard. I want to thank our Surgeon General for making this a very special event today and coming here and sharing with us. And I also want to thank each one of you for coming here. It is so important that you made the effort to come here and learn. And the beginning of addressing this epidemic is starting in this room with all of you. So thank you. First, I'll just briefly say I'm going to talk about some data. There's little data on Pitkin County, but there is some data on what's happening locally. And then I'm going to present 4 strategies that I've broken it down to that all of us can add to and participate in terms of addressing the opioid epidemic locally. This is an epidemic that as a community we all need to come together. There's so many segments. There's the medical community, the hospital, the pharmacies, the law enforcement, the emergency medical systems, and importantly, it's every community member that's going to make a difference here. And so when I go through these 4 strategies, which you'll see, there'll be very specific and practical steps that everybody can take. And I will show those soon. We can figure out. Okay. So in thinking about our community and our county, I've identified, just to start out, I think a couple of important points that make it different here. And I think some factors that actually may dangerously fuel the epidemic locally. Again, what Dr. Adams had mentioned is that a lot of times this is not on the surface. And I think in our community, that's very true, that a lot of the opioid epidemic is not on the surface and it's underneath. So we look at it, we're a recreational community, we're a resort community, there's a lot of outdoor activities and a lot of partying. There's a high rate of injuries, orthopedic injuries and other injuries, and therefore there's a high rate of people who have pain here and from other injuries that need to be treated properly. Mental health. Mental health has been identified here as one of the highest areas of concern from the Public Health Improvement Plan. We all know that mental health is linked intricately with substance abuse and with opioid abuse. Additionally, we're a rural community. There are a challenge in terms of limited access to treatment and to different options. And there's also limited county-specific data, which I'll show you, but I think we can't really rely on the county-specific data to tell us the full picture here. It's a map of Colorado, circled Pitkin County. This data we have on overdose deaths that are opioid-related. It's done by quartiles, so the highest in the state around Denver and the southeast are in the darkest. We are in the lowest quartile in terms of deaths that are opioid related in Pitkin County. I talked to the coroner. We've had 3 deaths here that are opioid related in the past 12 months. Actually, it's been 3 since November. On average, the state data tells us that there's 1.6 on average deaths per year in Pitkin County. So you say, there's only been 3 deaths. There are 3 precious deaths that potentially could have been avoided. But is there a huge problem here in our valley? Is it actually here? I think that death data, which Dr. Valak had mentioned, is not an accurate depiction of what's going on here. We need data on exactly how many people are misusing, are addicted, and are abusing opioids here. We need data on the near deaths, which we don't have, data on trauma as related to opioid use and deaths from that. And importantly, the impact of the workforce and on people's lives and their family and friends. How do you measure that? How do you put data on that? I think that's so important in terms of saying, is the epidemic local? And I truly think that it is here. And then in terms of law enforcement, a lot of this is underground now. There's illegal online sales that are behind the scenes that are very difficult to see and to capture. I also just want to mention before I talk about this, in the emergency room, we see it almost every day. The emergency services, the ambulance sees it, it's definitely here. And I bet each one of you have some type of a story. If you know someone who's misusing or abusing or is addicted, a friend of a friend or a family relative, and so we all know it's here. Okay, so the data that I do have. This is from the state. This is characteristics of controlled substance prescriptions, so it includes opioids and other controlled substances such as benzodiazepines in Pitkin County. Not sure how to, oh, there we go. Okay, so if we look at 2015, 42,909 prescriptions in Pitkin County in 2015 alone, and that's 9,650 different patients. Again, this is opioids plus other controlled substances. Now, what's reassuring here and kind of nice about what's been going on in the state is that we see that this is actually starting to be a downward trend from 2015 to 2016, and that's really nice to see. Now, this morning I actually talked with the people at the Prescription Drug Monitoring Program, which is such an important program in Colorado. It collects data on every physician's prescribing patterns. Every opioid prescription is being collected by the state now, and physicians are getting report cards in terms of how they're doing. It's great, and it's great for data collection. So he actually gave me data this morning, and I'll just share the numbers, on opioid-specific, just opioid prescriptions in Pitkin County. So in 2016, there were 9,837 prescriptions, and unique patients were 3,678. And again, that went down a little bit in 2017, so we're seeing some progress. I think these numbers are alarming here. I think they're alarming because we think about how many people live in Pitkin County. What's the census? There's about 18,000 people here. So more than half the people here have gotten some type of a controlled substance prescription. I think that's a very high amount. Another piece of data that I can share with you is that you may have heard before coming here that Pitkin County physicians have a higher rate of prescribing long-duration opioids such as OxyContin. This is important data, and this is a data that we are using to address physicians and prescribing patterns and to change locally. However, I also wanted to say in terms of the high-risk prescribing patterns that there's 4 other patterns here that we are actually below state average locally, so we're doing a good job. In terms of high-dose prescriptions, multiple providers prescribing prescriptions, overlapping days, and then prescriptions with overlapping benzodiazepine use. So we are doing better than the state average, but in terms of the long-acting opioids, which are dangerous, and we're going to be using a lot less of them. Okay, so I just wanted to do a list of quick opioids, just so everybody knows what we're talking about. I think a lot of people would be able to recognize these, but maybe not recognize all of them. So prescription pills, Norco, Vicodin, Percocet, OxyContin, Dilaudid, morphine, codeine, fentanyl patch, Demerol, all of these are opioids. The illegal street drugs, heroin, fentanyl, carfentanil, which is the very potent form, and opium. Okay, so on to our strategies. This is the bulk of what I'm going to talk about, and a lot of this has been mentioned already by Dr. Adams and Dr. Valek, and I think I just want to go over it and really talk specifically about what's going on locally and what you can all do in terms of steps. So the first strategy is reduce the supply, cut off the spigot, decrease prescriptions. The second is remove the excess, take back programs, and the excess meaning the excess opioids in your medicine cabinet. The third is treat overdoses using Narcan and naloxone. They're the same medicine. Narcan is the brand name for naloxone. And the last is to treat addiction. Medication-assisted treatment, and as I'm learning from our roundtable this morning, more education has to be on in terms of other treatment programs as well. So medication-assisted treatment, which I'll talk about more, as well as other types of programs. Okay, so the first one, reduce the supply. So I've been working on a team with Aspen Valley Hospital that we got together, and the hospital has launched a concerted effort to train physicians on decreasing use of opioids and what alternative to opioids are, and really addressing this epidemic. And we're addressing it in it's a 3-pronged approach from the hospital. We're addressing it in the emergency room, the emergency department, the inpatient surgery, post-operative pain. The anesthesia group is addressing this very strongly, and also in community physicians, and as well as the Aspen Valley Hospital clinics, such as the Basalt After Hours Clinic and the Snowmass Clinic. So these 3 different areas, and all 3, we're going to be decreasing the use of opioids, using other type of medicines, and having opioids not as a first line anymore, which we've all always been trained to do in the past, as well as other modalities, other medications and other modalities as well. And then, as it has been mentioned, that first prescription, the size of that first prescription is so important to decrease that. So that first prescription is going to be a lot smaller than it usually has. This is a coordinated effort in the hospital. It's among doctors and PAs and nurse practitioners, the pharmacists, nurses, administration. We're working with the Colorado Hospital Association on a state level, with the Colorado Consortium, and the Colorado Prescription Drug Monitoring Program. So this graph is key behind the effort, and I know we've talked about this, but I just wanted to show you the data on what it looks like. What's so interesting is that size of the very first opioid prescription that someone might get for a sprained ankle, for a sore throat, for a broken bone, for post-operative knee surgery. The size of that first prescription, research has shown that it is linked to your likelihood of addiction. So if you get a prescription that has 50 Percocet in it, you're going to be more likely to have long-term addiction than a prescription with 15 Percocet. Okay, so on the horizontal axis, you have days supply. On the vertical axis, the probability of continuing use, which is the probability of addiction. And you can see here, just after a first few days of a supply of opioids, your chances of a long-term addiction rises. So it's a really critical piece in terms of what kind of interventions that we can do locally to combat this epidemic. So I just thought I'd do a list of like, what are these other medications? What are these alternatives to opioids that we're gonna be now doing as physicians as a first line? Tylenol, ibuprofen, naproxen, lidocaine patches, nerve blocks, alternatives such as physical therapy, muscle relaxants, antidepressants, antiemetics. The list goes on. There's a long list, and it's retraining physicians to choose these first. And importantly, we're also trying to retrain patients to choose these first as well and use opiates as a last line if you still need them. The hospital is also starting an integrative medicine program, which is going to help with decreased opioid use and using alternative methods. So this right here is the key. It's the key to what all of us can do. We're all patients at one point, and what doctors can do. It's having a conversation. It's talking about what your options are, learning what the side effects are, the dangers of opioids, getting expectations about your pain, realistic expectations. When you break a bone, it's going to be painful. Your risk of addiction, everybody has different risks of addiction that they could get into. Other modalities, and lastly, if you need opioids, we're not advocating zero opioids. We know that there's a place for them. But if you still need them, the safe use of them, if it's still necessary, and also decreasing that size of that very first prescription, because often you do not need as many as you get. Okay, so the second strategy is remove the excess. And so these are called take-back programs, okay? And I'll describe what they are. This is a startling statistic. 4 billion prescriptions are filled in the US every year. 1/3 of that medicine goes unused. So I'm willing to bet that we all have medication in our medicine cabinets that are unused, and I'm sure that some of these are opioids. This has been mentioned earlier. I thought I'd show this graph, which is really powerful. On this axis, you have the number of days past year of non-medical use, so abuse or addiction. And here you have percent users. So basically, where are people who are addicted, where are they getting their supply of opioids? This gray line is given by a friend or relative for free. So it's far and away above any other source. And where is the friend and the relative getting the opioids? Most likely from the medicine cabinet. Also, bought from a friend or relative. Much lower, although it starts catching up over time, is prescribed by physicians in the red. Stolen from a friend or relative, bought from a friend or relative, bought from a drug dealer. And so these are all the sources, but the intervention, if we have it here in terms of getting rid of that source from the medicine cabinet and from friends and family and left over from old prescriptions so we make them smaller, we're really going to combat the epidemic. So, what do? It's really simple. We go into our medicine cabinet, we get all of our unused opioids and other prescriptions, and we go to our take-back box. We have one in Pitkin County, and it's at our sheriff's office. It's kept there very safely. It's this green box. Whoops, I don't know how to go back. Thank you. It's this green box. It's supplied by the state. It's a statewide program. The other boxes, we have one in Basalt at the police department in Elk Run and one in Glenwood Springs and the police department in 8th Street. And I think Carbondale is starting to become interested in getting one too. So this is how you dispose safely of your medications. We urge everybody to go into your medicine cabinet, walk them over to the sheriff's department, say hi to Joe, and dispose of your medications. And we have a happy, responsible community member doing this here. Don't do this. This is not environmentally sound. It pollutes our rivers. It pollutes our water supply. It's not an option, not a great option. Okay, number 3 of the strategies, treat overdoses. We've talked about this, Narcan, naloxone. So many of you have heard about this medicine. There's huge nationwide and statewide push and programs, and research has shown that communities that put this medication into the hands of community members, of non-medical people, into the friends and family, into people's homes, have had a decreased rate of opioid deaths. So this works. This is what it looks like. This is the package. What we're really pushing is the nasal spray. There's many forms of Narcan. The nasal spray is really nice and really effective. And what's so nice about it is that you don't have to use needles, you don't have to drop medication in that moment, which is such a terrible moment if you're ever in it. You just want something very simple. You don't want to use needles. Nasal spray is it. It's been FDA approved fairly recently. We have it in all of our pharmacies here, and this is what it looks like. I would love everybody here to have it who knows of a friend, a family member, a relative, or just to have it in their homes, because most of these overdoses occurs in homes. And we are the people that are going to find that person that's overdosed, and what do you do about it? So it's a life-saving medication. It has immediate effects. It blocks the receptors of opioids in our bodies, okay? Standing orders, that's been mentioned. A standing order means that anybody can walk into a pharmacy. We've been working with the 3 pharmacies in town. As of June 1st, they all have standing orders, and it's come from the state. So it's great. You can walk into any pharmacy. You have to talk to the pharmacist and say, this is what I want, Narcan. It's not going to be on the counter. You actually have to ask for it because it still requires a doctor's order, but there are standing orders from the state. So you don't need a prescription to get this. We can all walk in and get it. It's so nice that Medicaid actually covers this, and many insurances do as well. Again, it's the nasal spray that you want. So where is this now in our community already? It's in the emergency department, which it has been. We've been using it for years. The ambulance services, all police and sheriff vehicles now have it as of August last year. I think there's a big push statewide to do this, and we do have it locally. So they may be the first responders, and they'll have it in their vehicles. And it's in the high school as well. And this is just the beginning of where it all needs to be. It needs to be everywhere in the community. It's simple, it's life-saving, and it basically, it's like the EpiPen. It saves lives. Also, just to mention, that the Good Samaritan law covers anybody that uses it. So if you use it in the community, you're covered legally in any way. Not that that would ever happen, but. Okay, so I'm gonna show you a video. This is the video that shows you how to use it, but I really like this video because it has a whole scenario around what happens when you find somebody who is overdosed.
Narcan nasal spray is an emergency treatment for a known or suspected opioid overdose. The appropriate use of Narcan nasal spray can help you save a life. Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. If you encounter someone who is unresponsive and you suspect an overdose, first shake their shoulders and shout their name.
Kevin.
Ask if he or she is okay.
Hey, can you hear me?
Check for signs of an overdose, unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
I'm with somebody who stopped breathing. I think they've had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position. Continue to watch the person closely. If they do not wake up or respond to your voice or touch, or if they do not seem to be breathing normally within 2 to 3 minutes, use a new Narcan nasal spray to give an additional dose in the other nostril. Acute opiate.
I hope that was helpful. I just like that it gave a whole scenario. So a couple things is that you always want to call 911. It's just a holdover. That there are a lot of stronger opioids now that may require additional doses. You can also do a sternal rub, which I think Dr. Adams had mentioned in terms of shaking someone. Just make sure that they're not sleeping heavily before you do it. So what are the risks of Narcan? I just want to talk about, are there risks? Do you have to think about it in the moment? And really, it is incredibly safe. You're not going to overdose anybody on Narcan. When in doubt, use it. They may be unresponsive from something else, and you don't know that. You don't know if it's opioids or something else. You can use Narcan no matter what. If it's from opioids and they wake up, you have saved a life. If it's not from opioids and it didn't work, you did your best. And so it's very safe. If someone has alcohol or other drugs, it doesn't matter. It's still going to work. It basically blocks receptors immediately, and somebody will start waking up from an overdose, and you'll save a life. Okay, the fourth strategy, treatment for addiction. So we talked about turning off the spigot. We talked about getting rid of the excess. We talked about treating overdoses, and now treatment for addiction. Medication-assisted treatment, or MAT, is one way to treat for addiction. This is Suboxone. It's the main medicine right now in medication-assisted treatment. There have been methadone clinics as well that have been used in the past. We don't have a methadone clinic in our valley, and Suboxone is a lot more available. So it may sound confusing that we use a medication to treat an addiction. Suboxone is very powerful in terms of it stops people's cravings, it stops withdrawal symptoms, and it allows people to be able to get back functioning and into society. So it does a lot for them just to turn them around. There are a lot of other types of treatments in terms of treatment programs that are highly effective as well. This is a map that Dr. Valek showed, and I just wanted to show Pitkin County again to bring it home. In the lighter colors this is access to medication-assisted treatment. The lighter colors are 11 plus treatment locations. We're in the one treatment location. So we're rural, as I mentioned, where we don't have a lot of resources here. It's going to be a challenge to us to fight the opioid epidemic. But we do have one treatment location for medication-assisted treatment, and that's Dr. Gior Hahn. He runs the pain center of the Roaring Fork. This is his phone number. We have cards outside for him. Please take them if you know anybody that has an addiction and could use his services. So I think one of the most important points here is a conversation. We're trying to change culture and change stigma around people who are addicted and to help them get into treatment. And the most important thing that we can all do is have a conversation with people. It's so hard to bring it up. It's such a difficult thing to talk about. But if you can break that stigma and that barrier with somebody that you know and help them, you're potentially saving their life. Summary of steps. Reduce the supply. Talk to your doctor about other options for treating pain. Have that conversation with your doctor about pain. Local physicians, Aspen Valley Hospital, everyone is working to decrease use and decrease prescriptions, numbers, and size. remove the excess, safely dispose of unused opioids, use the take-back box that we have at the sheriff's office. It's green, it's readily available, it's easy to use. Please don't have it as a barrier to disposing your medications. And don't flush them. Treat overdoses. Everyone get Narcan, have it in your home. Know how to use it and when to use it. It's incredibly safe. You can only save a life. You're not going to hurt anyone from using it. And lastly, treatment for addiction. Talk to an addicted friend. Help them and a family member get into medication-assisted treatment or to enroll in a treatment facility or program that's going to help them. Thank you.
Thank you, Kim. That was an excellent overview with 4 simple action steps for us all to be able to take away from here and make a difference. I'd now like to invite our panel up to the stage, and while I'm doing that, if you're sitting up high and would like to come down and create a smaller, more cohesive group where we can have a conversation, I would love for you to do that. If you have any questions as the panel's coming up to the stage, please pass them to the center aisles. We have a couple ladies coming down each of the aisles that will be happy to take your questions because we want to be sure that everybody gets their questions answered this evening. So I'd like to start off with just each of the panel members. I know Dr. Levin and Dr. Valek have been introduced, but if you could each introduce yourself and tell us what you think is the one most important takeaway that you would like the audience or community members that are going to view this now or later to know.
Good evening. My name is Joe DeSalvo. I'm the Pickens County Sheriff. And I think the takeaway that I'm getting from this is our participation in some of the things that Dr. Valek and Dr. Levin had said. And I also want to acknowledge Dr. Adams for being here. I think that was an incredible stroke of luck on this community's part. And it was really a pleasure, I know everybody feels the same way, to hear some of his insight on this epidemic. The 2 things I'd like to take away from this is to just reinforce what you've already heard. Last August, the state was generous enough to supply law enforcement agencies with Narcan. Each one of my deputies carries 2 doses with them. We have not had an application yet, and I hope we never have to. But if we do, we are prepared, and I think the state did a great job of getting the message out to the sheriffs and police officers in our state. Second, to reinforce what Dr. Levin had said, our drug take-back box, we used to work with the DEA, which had basic cardboard boxes that once a weekend or a few times a year, we would go to events or a farmer's market or whatever, and we would put this cardboard box out and we would monitor people as they put their drugs to take back in. I think it's important to know that once you're prescribed these medicines and you're done with them, I think we've all learned that leaving them in your medicine cabinet is a real bad idea. We have had several break-ins and burglaries where basically the only thing taken was what was in medicine cabinets. So I've got to encourage you to use our drug take-back box. As I said, we used to have these flimsy cardboard boxes that we take around the state, and we came to you. Now you could come to us. We are a 24/7 operation. If you want to drop your drugs off in our office, no matter what they are, anything from aspirin to anything that are on these lists, there's a big green box that you saw in the picture. You can just open the door, put them in a brown paper bag, which that person had, so we don't have any idea what you're dropping in that or where it came from. It is really semi-anonymous, if you will. I don't know what you're putting in the box. Put it in, it's totally secure. It gets emptied, I think, once a month or so, and our stash is destroyed. So I think that's the two things that I would take away and that I would encourage this community to take advantage of. Look in your medicine cabinet, and if you have out-of-date drugs or drugs that you no longer need, medicines I should call them, not drugs, but please take them, put them in a brown paper bag, bring them up to my office 24/7, and you could dispose of them properly. Thank you.
My name's Alyssa, and I'm the Director of Pharmacy at Aspen Valley Hospital. One of my great takeaways is that opioids are rarely first-line treatment for many things that we see. As a pharmacist, I often have patients tell me, I'm just going to hold on to this Norco because if I'm out in the woods and I sprain my ankle while I'm hiking, I want to have something available. The best thing that you can keep in your mountain safety kit is Tylenol and ibuprofen. If you are in bad enough shape that you need to take a Norco or an opioid, you need to be calling Mountain Rescue. So I'd also like you to have a really good radio that you can phone MRA for. But I really want everybody to be aware. We start with Tylenol and ibuprofen first, and opioids really should be our last line of therapy.
My name's Kelly Locke. I'm a family physician in Basalt and a community physician. The thing that I think, two things that I would mention. One would be for those of you who might have family members on hospice or that remember that narcotics in those situations are a completely different animal, and they shouldn't be afraid to use them. You shouldn't be afraid to let your family members use them in those situations. For many of the other chronic problems we have, though, narcotics are not first line, and there's growing evidence that they may even stimulate nerve pain that normally wouldn't be as bad as it is. We all have cases where people have been on chronic narcotics, they've gotten off those medicines for various reasons, and you talk to them about their pain and they say, oh, well, it's much better than it was when I was taking the narcotic. The other thing is to bring it up with your physician. If you have family members or if you personally are on medication for narcotics or opioids, the dose is also an issue. There is a thing called the morphine equivalent, that is basically you can convert these various narcotics into morphine equivalents, and anything above 100 morphine equivalents a day really starts to increase rapidly the risk for overdose. You can obviously have issues at any dose, but the higher those doses go, you really want to start to taper those down if you can, and that involves a conversation with your provider when you do see them.
Good evening, I'm Tom Kurt. I'm a public health physician and medical toxicologist living in Aspen who was involved before I moved back here to Colorado in founding a certified regional poison center in Dallas on the model of the Rocky Mountain Poison Center in Denver, where I partly trained. I also worked as a federal regional medical officer for the FDA, which approves the dispensing practices of drugs. My experience to relate to you, because I'm on Dr. Valek's committee statewide and other statewide committees, is that many of us involved in drugs and drug issues have issues ourselves and our own families. For instance, my father died at age 52 from addiction to alcohol. And look at yourself and your own families and look at what you have learned within your own family from these experiences. To help understand this issue better as a layperson, you might want to look at this book, which was a bestseller in the New York Times, Dreamland, which is very popular and describes the heroin epidemic and how it started with black tar heroin and pain clinics in southeastern Ohio and in West Virginia. Also, there's a book called Broken, My Life of Addiction and Redemption that describes the life of a drug addict. So thank you for all being here, and I'll pass this mic back.
Dr. Locke, while you have the microphone, could you share with the audience what symptoms or signs might they look for in a family member, loved one, friend that might have an addiction that might not already be recognized?
Well, sometimes it's hard to to determine that. They can oftentimes hide the addiction, and if they're taking a chronic level, they may not show signs or symptoms. But some of the things we think about, especially like in kids or adolescents primarily, if they seem, side effects from the opioids, constipation, obviously, drowsiness, difficulty to arouse, nausea, vomiting, dizziness. Dry mouth is a common side effect of opioids, sometimes headaches, sweating, mood changes. Sometimes in adolescence, some of these are, things that may be hard to tell whether it's a normal adolescent or side effects. Are they sleeping in all the time? Are they sweaty all the time? Well, that's things I commonly see with my boys. A change in grades. Anything we would think about, not just opioids, but other drugs of abuse. A change in grades, skipping class, dropping friends that they've had for many years, change in interest in their usual things, change in appearance, change in eating habits, and activities that they normally do. Some of the risk factors we think of for anybody is if they have acute or chronic pain, and they're receiving a prescription, that can certainly put them at risk for developing an addiction and then ongoing use. We've heard already the initial exposure oftentimes is the drug cabinet, and so not having those around that would give them exposure, but also the exposure from friends or family that give them pills and start them on that pathway. Mental wellness, if there's a history of family history of addiction in the family or mental wellness issues, that can put them at risk for developing an addiction to opioids. And then there's oftentimes an overlap between other drugs or substances, so alcoholism and other medicines that might be drugs of abuse. If they have those risk factors already, they could be at risk for developing opioid addiction.
Thank you. And just want to remind everybody that it's a myth that opioid addicts are homeless people or just people out on the street. It can happen to anyone in this room with the first prescription. So we want to remember that.
And we might bring up the issue, the idea of physical and addiction versus abuse. There are people that are on chronic opioids for and not changing the dose, and they may not be abusing it in many ways, but if they stop it, they will have withdrawals. So there is that issue that in certain situations there may be if it's not being abused. They may not be having other issues with it, but you can be physically addicted to it, but not necessarily abusing it. But the risks for opioids are always there as far as escalating the need, and they become less effective, and so you use more and more, and then you get above that cutoff where we start to really worry about side effects.
Thank you. Alyssa, could you tell us a little bit about what might look different if I were to come into the hospital and was having pain and wanted treatment? What might that conversation look like, or what's going to be different now as we try to reduce the use of opioids and access?
As Dr. Levin mentioned, we are participating in a study with the Colorado Hospital Association in the emergency room only, but we as a hospital felt that we needed to take it to our inpatient area and also our community. But the study is actually in the emergency room. So if you present to the hospital with a headache or back pain or even a sprain or strain or a simple fracture, the first medication that we're going to give you is probably going to be Tylenol or an NSAID such as ketorolac or ibuprofen. And then we may go to something else like ketamine or lidocaine infusions. So we're going to start with our non-opioid options and only go to an opioid if we have to. I think one of the great things about our emergency physician group is they're very progressive. They jumped on board right away. And I've already started to see a decrease in our opioid usage. We used to go through so much IV hydromorphone or Dilaudid a week, and I don't think I've had to order it in a month. So that's really exciting. And then again, as Dr. Levin mentioned, our emergency room docs, we are encouraging them to start with 8, 10, maybe even 15 max pills that they send you home with, because really the opioid should only be used for breakthrough pain. You should continue to take Tylenol and ibuprofen or whatever might be indicated or prescribed to you, and then the opioid would only be used in the event that you were having pain, that it wasn't helping. So that's what we're doing in the emergency room. In the inpatient setting, our anesthesiologists are also very progressive and great, and we've already started to see them using different types of nerve blocks, using long-acting bupivacaine, which is a local anesthetic. And we've had a number of patients who have had total knees in the last couple of weeks who have used one oxycodone pill their entire stay, which is completely different from what we were seeing. We were typically seeing patients take 1 to 2 pills every 3 hours. So I think that is speaking volumes to what other modalities that we have at our fingertips can do.
Thank you. Dr. Valek, we know that prevention is the key moving forward, but we have, as you've shown, large population here in our own state and in our community that are already addicted to opioids. Are there plans to address the lack of medication-assisted treatments around the state, as well as, I think, one of the big things that we deal with here with the mental health issues is lack of ability of people to afford to go to treatment centers or to get treatment. Are there discussions around that at the state level?
Yes, it's the 90% treatment gap that I mentioned, and that is pretty well known that it's difficult to get treatment, is not lost on people at the state and federal levels. Federal money, most of the federal money that's being granted now, 80%, 85% of it is going towards treatment expansion, which is, I think, totally appropriate when we have that size of a treatment gap. You can make good arguments we should be spending more on prevention and harm reduction and naloxone and treatment, and our limited dollars being what they are, most of them right now are going towards treatment expansion. So it's good that in the last year and this year combined, we got about 15 million federal dollars to put towards treatment expansion in Colorado through our existing system. We believe now we're treating about 700 or 800 more people receiving medication-assisted treatment than were a year ago. So it's not enough, but it's meaningful progress with the dollars that are coming to try to do this very quickly. The state is also putting in more effort to do this, training more doctors, incentivizing counselors to do the counseling part, because really medications assist treatment, and the treatment is biopsychosocial and people's living situation. It's really counseling and social work and systems level things like Dr. Adams talked about: jobs, housing, security, food. Those are what get people back to their lives, and medications just simply calm your brain down well enough so that you can carry the water and do that work to get your life back. So we need to bring all of those things along, and the state is funding programs to train more counselors, to train more doctors. Very controversially, one of the 6 bills that we managed to get passed was to require our Medicaid department, the Department of Healthcare Policy and Finance, to apply for a federal waiver to cover detox, inpatient, and residential treatment under Medicaid in Colorado, where we normally have not covered that as a benefit. And the legislature put $35 million of our marijuana tax revenue fund into that, and the governor signed that into law just a few days ago. So that's encouraging that we're going to get soon this federal waiver and now have Medicaid coverage for detox, inpatient, and residential. By putting in $35 million, the state will draw down $140 million federal to have $175 million a year to put into treatment, which is coupled with the other federal dollars, we'll be pushing $250 million in treatment funding that we have not had. So we're hearing it. We're doing everything we possibly can, and we did. We fought tooth and nail, and it was to the last minute with the governor deciding what he's going to sign. And are we going to put the $35 million towards inpatient treatment for Medicaid, or to bridges and roads, or to prisons? And they're all good things to be thinking you need to spend your money on. And we were just doing everything we could, and begging, pleading, arm twisting, anything we could do, and he signed it. So we're doing what we can to expand treatment.
Wow, I think that deserves a round of applause. I did not know the answer to the question. That was actually my question. I was worried I might be putting you on the spot, so I love that answer. Kim, we have a couple questions from the audience related to Narcan. The first question is, if a person's not breathing and you're using a nasal spray, how is that helpful?
It's a great question. So inside your nose, you have a mucous membrane that's very thin, and there's a lot of blood vessels. If anyone's ever gotten a bloody nose, you know that the blood vessels are very thin and right there. So you can actually spray a medicine up someone's nose, and it absorbs right into the mucous membrane of their nose. It doesn't go, they don't need to take a breath and have it go down into their lungs to make it work. It's working right inside their nose. And in fact, not just Narcan, but we use other medicines that way in the emergency room. Instead of, to avoid using, for kids, for instance, using a needle stick and making it less traumatic, we'll use medicines up their nose for that reason. So it's very effective, and they don't have to be breathing.
And the second question regarding Narcan is, you mentioned that anybody can get it from the pharmacy because of the standing order, but what's the cost if I go to get Narcan at the pharmacy?
Hopefully your insurance will cover it, and Medicaid does cover it now, the nasal spray. And I think a lot of insurance, the last time I talked with Carl's Pharmacy, a lot of the insurance carriers were covering it. It's about, I think, $120 if there's no insurance coverage. So it's expensive, and it's a lot more expensive than the injection form. There's a couple different injection forms. One, you have to draw it up yourself. There's another auto pen injector. The one that you draw up yourself is a lot cheaper, but really at the moment, I don't even know that that's going to be effective for anyone who's non-medical to be able to do that. So we're really pushing the nasal spray if you can have that at home. The auto injector, I think, is very expensive, and I don't even know who covers that, actually. There has I don't know who covers that. I've never actually seen it. But yeah, hopefully most insurance carriers will cover it. And I know Medicaid does, which is excellent.
But lucky you who came tonight, there is free Narcan that you can grab on your way out tonight. And if you don't think you need it, please give it to someone that you know that you think might benefit from it. And I don't know, I believe Mind Springs got over 50 free doses. And Karen, can you tell me if they don't get it tonight and somebody says, well, where could I get free Narcan because I can't afford to get it at the pharmacy? Could they go to Mind Springs and get a free dose until they're gone? Okay. Okay. Thank you.
And I just wanted to add, if you have a friend or family member who you think would really be able to use it, please share with them the video and how to use it and the scenario around using it, which is so important. Okay. It's great to educate, spread the word to others.
Last questions for you, Joe, unless somebody else in the audience has a question. What are you seeing in the community, out in the streets, and how do you address the crime of people who are using out on the street and yet help the addict?
Well, I think mostly what we're seeing is, which actually has dropped significantly since the 90s when this was really at fever pitch. In the 90s, we were seeing a lot of prescription drugs taken from drug cabinets. People would have a party and they'd see their medicine chest rifled, or break in a home and get some there. But we've seen that go down. And I don't know if that's because the prescriptions are becoming more readily available or not. As far as I told Dr. Adams, that I feel like I'm at the bottom of the chain here. By the time we see people, they're addicted, dying, or dead. And so that's part of the crisis that we're dealing with, is the back end. I would like to see more treatment available for us here in Pitkin County. I wish there were more treatment programs or better treatment programs that were available to people here. But as far as criminal behavior, we're just not seeing it. But we do see a lot of people struggling with this addiction, and I'd like to get them the help they need. I just wish it was more readily available here.
Okay. I do want to comment that we've talked a lot about getting rid of the prescription drugs that you have filled and are in your cabinet, but there's also people who get prescriptions from the physician, decide not to fill it, and leave their prescription available for somebody to pick up and try to get filled. So please, if you're not going to use your prescription, make sure you either tell the physician at the time, no, you know what, I don't think I need an opioid for my pain. Or if you do take it and decide not to fill that prescription, please shred it. Don't leave it sitting around in your home.
Actually, Lori, I'd like to add one more part to my answer. The other place where I'm seeing it is when people are taken into my jail. I don't know that they're addicted to pills or opioids until maybe a couple of days later when they're detoxing. And we don't allow Suboxone in our jail, so we usually treat them with an Xanax. I'm sorry. We usually treat it with Xanax, you know, we don't, but that's where I see it most, is people come in, they look like the average guy off the street that may get a DUI or was sentenced for another crime, and after a few days we see their behavior change significantly and we realize they're detoxing. But outwardly, when they come in the jail, they look like any one of us here. It's not until a few days later we really see the signs and symptoms of what they're going through.
Thank you. So in closing, we hope that tonight is just the beginning of raising awareness about the opioid crisis and what we as individuals, parents, community members, medical professionals, public health, and law enforcement can do to reduce opioid access, use, addiction, and death in our own backyard. I challenge each of you to have the conversation with loved ones and friends and continue this conversation, to clean out your medicine cabinet, and to think about your own expectations about pain medicine, and by all means, take home a dose or two of Narcan. In closing, I'd like to thank our speakers and the panel, Jennifer Slaughter, Aspen Valley Hospital's Community Relations Director, Jessica Garentz, our Marketing Coordinator, Dr. Ken Levin, the Pitkin County Medical Officer, Alyssa Franklin, our Pharmacy Director, Elaine Gerson, our Chief Transformation Officer, Karen Koneman, the Pitkin County Public Health Director, Pat Bingham from Pitkin County Community Relations, who are all part of the planning committee for this event. And I'm so grateful that we as a community are collaborating already and that we have such strong relationships. And this would not have been possible without the collaboration of the hospital and Pitkin County Public Health. I'd also like to thank MindSprings for sharing their resources and donating the doses of Narcan tonight. And Jonathan Geller, who's behind the scenes up there, behind the window, who has the IT technical expertise, who donated his time this evening to make this event possible. He set up everything, and he'll have tear down afterwards, as well as the Aspen School District for allowing us to use this beautiful theater for this event. We're very fortunate. So in closing, I thank you all for coming. I hope that you've been enlightened and made more aware of this issue and the impact of the community and what role that you can play in helping us to reduce the opioid crisis here at home. Thank you all.